All right, H&S, best practices, subsequent visits. I feel more comfortable talking about this. So for all subsequent visits, the healthcare record must include SOAP notes, okay? SOAP notes. How many of you miss your travel cards? Okay? I miss my travel card. I still have a stack of them in my back closet. And I won't let my staff throw them away as if I'll ever get to use them. But it's an old friend. You don't want to get rid of your old friends. But SOAP notes needs to be a little bit more content. So you need to have a fresh, creative, original SOAP note. Now, I was in Colorado Springs a month or so ago teaching an ICD-10 seminar. Guy comes up to me at the break and says he does IMEs, or not IMEs, he does record reviews for one of the carriers in the Colorado Springs area. And he said, I can tell you what every doctor's EHR is based on what I see in their records. So he said everybody's essentially using the same formats. The format's not so bad, but it's the same content. So there's no creative content in their records. So that's the other thing I would say about your EHRs. You need to have custom notes. Not to say that you don't have, the patient comes in on Monday and Tuesday and Wednesday they come for an adjustment and there's really not a lot of change. There's not a whole lot to report other than the fact there's no change yet in what you're doing with the patient. But you need to have some creativity with your notes, some customization in those SOAP notes. So make sure you have a system that does that. All services provided to the patient should be in the SOAP note. All tests performed and the results of those tests should be in the test notes. Again, it's great to be able to, you're all very good about putting the CPT codes in there, but you need to explain why you took the low back films or why you did what you did. So make sure you're getting that part done too. Any patient education and or home recommendations and or any DME, all right? Again, whether it's a lumbar support, an ankle support, you're subscribing or suggesting prescribing a TENS unit for a patient, that needs to be very detailed as to why you have that for the patient in your SOAP note. And it also should include responses to treatment. We want to see progress. Gone are the days we just put arrows, different arrows based on how good or not good they're doing. So put some response to the treatment. Visual analog scale is an example, or just articulating what's going on with the patient. Patient is now back to work. The patient's back to working out at the gym 3 times a week or whatever it may be. Significant changes in subjective complaints, including, but not limited to, frequency and intensity of pain or discomfort and review of ADL deficits. Now, you're not reviewing these and updating these every single day. When are you doing it? When they change, right? So you're asking these questions along the way. I really don't ask a whole lot about pain on a day-to-day basis. I'll ask, well, how'd you do over the weekend? Well, then with that open-ended question, then I'll get, well, I had a great Saturday, did some yard work. I woke up Sunday morning. The leg pain flared up again. I had to ice it down. Today, I'm feeling better, but I'm not as good as I was last Thursday. Great. So I've got a lot of good, valuable information that I put into the record based on that. So I don't necessarily ask patients, how's your pain level today, every single time they come into the office. Any changes to the diagnosis, we'll want to have that in there. Are you changing the orders or adding or subtracting things? Changes to treatment and the rationale for change. Okay? So you've gone through, that patient has had a slight aggravation. You know what? We're going to go back. We were just doing STEM on the patient. So today I'm going to go back to doing STEM and ultrasound on the patient. Or maybe I'm going to throw an ice pack on the patient. Why'd you put an ice pack on the patient? Okay? Again, it should be congruent with what it says in the subjective end all the way to the end where the CPT codes are at. Okay? It needs to have that rationale. And per the Board of Examiners practice guides, the frequency of treatment should gradually decline until the patient reaches the point of discharge or converts to maintenance or supportive care. So there should be changes in care. It'd be great to see everybody 3 times a week. You know, in the old days, it was 3 times a week for 4 weeks, 2 times a week for 4 weeks, 1 time a week for 4 weeks, based on what? Now, that's what I was taught in a practice management seminar. But it's not based on what's accurate or important for the patient. In this case, it's not substantiated by our examinations and outcome assessment forms and all that. The patient's healthcare record must include evidence of the evaluation of the treatment's effectiveness and the patient's progress as it relates to the treatment goals. Okay? Again, the fact that their pain is going down is good, but how's that affecting the functional goals? Okay? Are we relating that back to the goals? If the pain has gone down, but they're still not back to work, what's going on with the patient? Why are they not back to work? What do we need to do? What do we need to change? Okay? The patient's healthcare record should also clearly and objectively demonstrate when maximal medical improvement, or MMI, has been reached. This is excuse me, this is one area that we often miss. We're excited to finish things off. We do our final re-exam, but we don't explain the patient's, we don't have a discharge note. We don't say, well, the patient has reached these goals and is doing this, or has these residual symptoms or residual issues related to functional changes in their spine. So you need to put a little a narrative at the end of that report, at the end of that date when you're releasing the patient as well. And we'll talk more about that. And the patient's healthcare record should also include patient status on discharge, recommendations on discharge, and prognosis. So sometimes we're releasing patients without any further care, just on a PRN basis. Sometimes we're very specific. We're putting them on a supportive care plan based on the residual issues they have in their spine. It could be pain, it could be functional residual issues, but just put that. We're talking about a sentence or two that really clarifies the patient's condition. Okay? And all services provided at each subsequent visit, as well as the number and frequency of those visits, must be consistent with the patient's chief complaint, clinical findings, outcome assessments, diagnosis, and treatment plan. Again, that thread should be consistent throughout the entire course of care. And that's what establishes medical necessity. All right? Good. Any questions there? All right, we're moving on. Let's talk about CMT. The record, the clinical record will include all manipulations performed, include location and specific segments or regions manipulated. Very important that you're getting those segments in there. I have a record, kind of an ongoing record of segments throughout the course of care. I can bring over my previous notes for that particular area, so I can see that as that's changed over time. Again, adding more value to what's in the notes. Include documentation to demonstrate subluxations by radiographs or physical exams. We talked about that earlier. And if the subluxation is demonstrated include the documentation to demonstrate the subluxations by the physical exam. But if it's demonstrated by physical exam, the clinical record will establish that 2 of the 4 part, excuse me, I'm kind of using my words incorrectly, establish that 2 of the 4 part criteria met pain, asymmetry, range of motion, tissue changes, and one of which must be range of motion or asymmetry, like we talked about before. And again, substantiate that manipulations reported to payers are consistent with the patient's chief complaint, objective clinical findings, diagnoses, and the treatment plan. Again, so it all comes together. All right? And modalities. The clinical record will include all DME modalities, therapies performed, and the rationale for each, duration of each, and areas of application as applicable. Okay? So I was talking with a friend of mine who last year averaged 1 foot levelers orthotic per day for the year 2000. Well, this is up to date, 2015, and a few more in 2014. But he didn't bill insurance for all those. He was able to distinguish the difference between what was necessary and what would be helpful for the patient. So what was a medically necessary thing and what would be a helpful thing. And so it's part of what he does in his practice, okay? So he's able to distinguish that, and it's been very interesting how he's been able to do that over the time. And that's not just H&S patients, but it's Medicare, it's cash, everybody. So that's a lot of orthotics. But again, when you're billing those orthotics, or whatever the procedure or product may be, it's got to be consistent with what? The chief complaint, the goals, yada, 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 down that line throughout the course of care. Substantiate those therapies, as we've mentioned. If time-based therapies are performed, constant attendance, or therapeutic procedures, the record will reflect the actual time the therapy was performed. So time-based therapies, we spent a lot of time talking about this over the last 2 or 3 years, how to document time-based therapies. And if you need a little update on that, just go back into, well, actually your practice protection plan has information on that. But make sure you're documenting that time, okay? Again, it's not 9:01 to 9:16. It's 12 minutes, 13 minutes, 15 minutes, whatever it is for that particular patient. And during the initial phase of care, no more than 2 therapies or modalities per visits are considered usual and customary. And there should be a reduction in the number of therapies as the patient's condition improves. Okay? Yeah.
Going back to the foot leveler's distinction of helpful versus medically necessary, clinically justified, et cetera. I had a patient this past week. She has a significant lumbar scoliosis, idiopathic. She has some DGD in her cervical spine. And one of her, besides the serious and significant low back pain that's just been hounding her for years, she also had some paresthesia in her arm, numbness, tingling, numbness in her first 2 fingers, and just tingling down her arm. After 3 days in her orthotics, her back pain felt better, and the numbness and tingling reduced to the point she says she knows that there's still a tiny bit of numbness there, but it's not really numbness.
Sure.
In 3 days. Now, I can't really, from a medical standpoint, quote unquote, not that I know about that, but justify orthotics, but from a chiropractic standpoint, gee whiz, and from the neurological understanding of what chiropractic is about, I'm like that guy. Every one of my patients should have orthotics because of the way it influences the entire spine. So I know that's the leading edge of how chiropractic is educating the insurers about what's really going on. How do we push that boundary?
Sure. Well, let me take a step back from that. I believe that every man, woman, and child should be under chiropractic care, okay? But guess what? It's not covered by insurance, right? Not every adjustment's covered by insurance. It's not designed to do that. So, but I still emphatically believe that every man, woman, and child should be under chiropractic care at some level, right? So the same thing would be orthotics. I think it'd be great if all my patients, or at least most of my patients, would have orthotics, custom-made orthotics. So in my office, I use the foot leveler, so I do scans on patients, and then based on that diagnostic criteria, I make recommendations for that. So when I can justify it by their presenting complaints, then I'll bill the orthotics. And there are a lot of times when I'm making those judgments later on in the course of care, when that SI joint, I just can't get it to stabilize. And then we go in and we do a scan on the patient, and then we make a clinical determination whether that is imperative and medically necessary, or whether or not. So, really, this is where the clinical judgment comes in. And I am always a fan of billing cash-related services. So even though it's not covered under the corporate medical policy, your patient may still need it, and it'd be a service or a product that you just bill for the patient directly. Okay? Does that sound good? Anything else you'd like to say? Okay, good. All right, re-exams. I'm big on re-exams. I love re-exams. It is a great, even before clinically and documentation. If we get to this part at the end of the day, we talk about how I take patients from active care into maintenance and supportive care. A lot of that takes place, patient education takes place during progress exams and re-exams. It is a time, it's a big deal for me. So guess what? It's a big deal for my staff, and it's a big deal for my patients. I had a patient the other day, I swear to God this happened 2 days ago. It was Wednesday night, 3 days ago, I guess. And she was scheduled for a progress exam, and we told her she needed to come at a certain time, and she didn't walk in the door till like 3 minutes before 6. So I said, we're not going to do a progress exam. I had to go somewhere. I said, we'll adjust you today. Let's reschedule it for Monday. She got mad at me because she was looking forward to that opportunity to find out where she was in her course of care. A little unreasonable, shall we say, but I saw her on the following, I'll see her on Monday. We'll go through the process. But that's the hype we give towards those progress exams. So clinically and documentation are important, but it also is a big time to share the outcome assessment information with them, share their progress. We talk about their presenting complaints. And again, I like to see a certain volume of patients, so it's not an extensive amount of time. I'm not spending 15 minutes talking about this, but it's very specific information that we share with the patients. That's also often the time, the first progress exam, that we start teaching stretches and exercises, pushing them into doing more active things outside of the office. And so it's a big deal for that progress exam. So it's a big deal in your notes too. So those re-exams or progress exams, whatever you call them, should be done approximately every 4 weeks or every 12 visits, whichever comes first, or the medically necessary point in time. Again, I say sometimes that may be at 5 or 6 visits with a given patient. So, but at the very least, every 4 weeks or 12 visits. And if properly done and documented, you provide objective evidence of patients' progress towards treatment goals, determine the effectiveness of treatment to date, and whether treatment should be continued, modified, or discontinued. Help to determine the appropriateness of additional care that can be billed to the payer, and determine when MMI has been reached. Okay? So very important. There are times when you'll do a clinical trial of care, right? You look a patient in the eye and you say, I'm not sure that I am going to be able to help you, but this is what I think we should do. Let's do a clinical trial at the end of whatever number of visits, 6 visits, 9 visits. We're going to do a reassessment, and then we'll determine whether further chiropractic care is warranted or we'll refer you out. That's another example of when that should be done. But those re-exams should be important. They should be important to you, your staff, and certainly to your patients. So the record will include all the re-examinations performed, all the tests performed, and the results of those tests, all clinical examination findings, objective and subjective, and include sufficient documentation to substantiate the specific level of E&M coding reported. 99211, 212, 213, and then also vitals, okay? Updating those vitals in your practice as well. It's not sufficient to merely perform and document the re-exam. The re-examination must include the use of outcome assessment tools to measure and compare the patient's progress towards treatment goals and to determine the effectiveness of treatment provided and to help establish when MMI has been reached, okay? And the clinical record must include a summary assessment of the outcome of this evaluation. So again, I do a little bit of that in my subjective section and then in my plan section as well. All right? Good. All right. Any questions on re-exams? I'm kind of curious, how are re-exams going? Generally speaking, I'd be interested, Dr. Binder, as you're reviewing kind of the overall statistics of the group here in North Carolina and South Carolina, are people doing a better job of performing the re-exams?
it has been very helpful that our state has had you in this position teaching this year after year after year. And I think over the years we've seen an improvement, but we're still probably 50-50.
Really?
Yes.
Okay. So that's I'm surprised by that number, 50-50. Again, you get paid to do these. They're required. Number one, they're required, okay? Number two, you get paid to do these. And number three, and most importantly, they provide substantial information to make clinical decisions. So that's good to know. So again, if you're not doing those on a regular basis, you know, a quick little measure, it's not the gold standard, but a measure, look at your CPR. How are you doing? They kind of give a rough number estimate of progress or re-exams that you should be doing. Are you way below that? Or are you way above it? Maybe you're doing too many of them doing that, but kind of gauge yourself on how you're doing that in your practice. But there should be some system in your practice. Now, the other thing that I would recommend for progress and re-exams is that they're scheduled. Okay? Don't just, when they come in and they're feeling good and you feel like you've got a few extra minutes that you're going to do a progress exam. I would build up to that. I would schedule it so the patient knows this is an important appointment. And then again, most importantly, you've got time to do everything that you need to do. So we have specific amounts of time. I only do so many new patient, see only so many new patients, and do only so many progress or re-exams in an hour. So we have to spread those out, and my staff knows how to spread those out on the schedule so we can get the information appropriately. Okay? Good. All right, so what does medically necessary actually mean? You know how you're going to find out the answer to that question? Is you're going to have to see me, come back after lunch, and I'll give the answer to that question. Okay? That's my teaser, okay, medical necessity.